Good evening and welcome to Seeing Eye to Eye right here on blackdoctor.org. I am your host this evening, Shamika Rhymes. Let me know in the chat where you are watching from. Let us know how your week's been going. It's a lot been this week, right? So tonight we're going to talk about a critical topic, glaucoma. And this condition affects millions, but with early detection and the right care, vision loss can be prevented. So we'll hear from two experts about the causes, risk factors, and symptoms of glaucoma. Plus, we're going to talk about the latest treatments, cutting edge research, and how clinical trials are shaping the future of eye care. So, you don't want to miss this important conversation. So, what I want you to do, and I'm going to give you all a second to run and hit that share button because you never know who in your network may need to see this. And again, let us know where you're watching from. And if you have any questions at all throughout the show, drop it in the chat and I'll be sure to be checking to see what those questions are. So let me introduce you to tonight's panelists. So tonight we're joined by Dr. Monique Barber. She's a board certified ophthalmologist with over 20 years of experience in both clinical practice and academic teaching. She's the medical director of Clearview Eye Center in Lake Worth, Florida, and the founder and CEO of the Smiles and Vision Foundation, which is dedicated to addressing healthcare disparities. Welcome, Dr. I was getting ready to try to put a fancy spin on it, Barber.
Good
Welcome.
evening, Shamika. Good evening. I'm so honored to be here. Thank you so much for the opportunity. I'm looking forward to our discussion.
I am too. And also joining us tonight is Dr. Janelle Davison. She's an optometrist with 18 years of experience in private practice. She's the founder and owner of Brilliant Eyes in I'm not sure I should have asked you this, Smyrna or
Yes.
Smyrna? Smyrna,
Smyrna.
Georgia. Smyrna, Georgia, and the Visionary Dry Eye Institute. And she's recognized as one of the most influential women in optical for innovation. And she's also the co-founder of the Paradigm Software, an award-winning optical solution. So welcome.
Welcome. Thank you for having me. I appreciate it. I'm so excited to be here with you tonight and Dr. Barber, one of my eye care sheroes. So it's going to be a great night for you guys.
Yes, yes. And we are all sorors, we just found out. So
Yes.
I'm super excited about tonight. So, again, everyone in the chat, make sure you drop your questions and we'll be sure to get to those because tonight's topic, like I mentioned, is glaucoma. So, I'm going to start with you, Dr. Barber. We often hear that glaucoma is referred to as the silent thief of sight. So, what is glaucoma and what are the causes?
Well, glaucoma is really a group of eye diseases that eventually damage the optic nerve of the eye. And the optic nerve is that structure that takes all of our visual information to the brain so that we can perceive objects and images in space. And it's often caused by abnormally high pressure in the eye, but it can be from a multitude of other problems. And we'll get into those a little bit later. It is a leading cause of blindness. Quite often, patients don't have symptoms whereby, they may not experience pain or vision loss until the very, very late stages of the disease. It affects the young persons, it can affect the elderly, and we'll talk more about who's at risk. And unfortunately, it's irreversible. However, early detection and treatment can help slow or prevent vision loss. There are several types of glaucoma, I might add, including open angle glaucoma, angle closure glaucoma. In some cases, the pressure can be normal. Babies can also get glaucoma, and this is a type of congenital glaucoma. And glaucoma can also be caused by systemic illnesses.
Thank you. Dr. Davison, who is most at risk for developing glaucoma and why are individuals of African descent more affected by it?
So Dr. Barber did a really good job about getting a big overview of glaucoma. I think for this talk, we'll probably be focusing mostly on primary open angle glaucoma. And so who's most at risk for that particular most common type of glaucoma? I jokingly say one lot is just looping around the sun. Age plays a role. The older you are, particularly 65 and up, your risk increase for most diseases, and glaucoma is no exception. As well as diabetes, particularly uncontrolled diabetes. There has been a connection between diabetes and glaucoma. individuals that have a large optic nerve. So Dr. Barber talked a little bit about the optic nerve. It's a part of the eye that is connected to the brain, and that's actually part of the eye that this condition affects. It contributes to your peripheral vision, and there's a size to the optic nerve that is average. I jokingly say my patients there's an average height, there's an average shoe size. I'm below the average height, vertically challenged, but there's an optic nerve size as well. And so those that have a large optic nerve, their risk is higher for potentially developing glaucoma as they continue to live. Long-term steroid use. So there are numerous health conditions where you have to take steroids to manage that condition, but it does increase your risk for glaucoma. And then your last question, people of African descent. And so you, we hear about glaucoma. About 4.2 million people in the US have glaucoma. About half of those cases are people of color. And so I really kind of dug deep with this so I can get a really good scientific answer to figure out, why is that? And so there is a protein, actually there's a gene, a MYOC gene mutation that they think that increases the prevalence of glaucoma. So this particular protein or this gene is in the aqueous humor, which is a fluid that's in the eye, and that's really important to keeping the eye its shape, and it helps to bring the nutrients and oxygen to the optic nerve. So you want this aqueous to flow properly through the eye. And there has been some research that's shown that this particular MYOC gene, when it's mutated, it increases the risk of open angle glaucoma. And some studies have shown that people of African descent have a higher prevalence of this gene mutation. So a lot of it is genetics. A lot of my patients are predominantly of color. I'm about 70% in my practice here in the Metro Atlanta area. And I get that question all the time. Well, why? Why me? Why people of color? We get everything. And so some things are genetic related. And this is one that may have a genetic component, but we're still studying. There's still a lot that we don't know about glaucoma. And we'll get into a lot of the advances in surgical that Dr. Barber will talk about today. But those are some key risks that we do know that are noted with glaucoma.
That answered my question. I was wondering if genetics played a part or if it was hereditary. Um, yeah, thank you for that because I had no idea. Um, Dr. Barber, are there some health issues that can influence? You mentioned diabetes, but are there other health issues that can influence the onset or progression of glaucoma?
There are several health conditions that can influence the onset of glaucoma. In particular, we really look at those patients who are diabetic. Are those patients in particular are particularly at risk because there can be a decrease in the blood flow to the optic nerve. So we have the case of the diabetic and also the hypertensive patients, especially those who are poorly controlled. And we see a triad at times of ocular diseases, which includes glaucoma, the development of glaucoma, in association with the development of cataracts and diabetic retinopathy simultaneously. And so we call that the triple threat when it comes to eye diseases. And these diseases can exist and cause blindness, which is irreversible, and it's really challenging to treat when you see them occurring at once. So that's
Thank
one
you.
uh, condition. I would also point out the fact that patients who are known to have a history of migraine or any kind of vascular issues that can compromise the blood flow to the optic nerve are particularly at risk for glaucoma as well. So we want to pay close attention to those patients with a history of migraine or any kind of vascular disease, vasculitis, temporal arteritis, and conditions such as that. And one thing I might want to point out too, and it goes back to our diabetic patients, there were some reports that were surfacing late in 2024 that a lot of our diabetic patients who are on Ozempic and our GLP-1 agonists were at risk for an entity called ischemic optic neuropathy. This kind of disease certainly represents a risk to the health and perfusion of blood to the optic nerve. So we want to put our patients who are diabetic and those who are not diabetic that are using GLP-1 agonists on alert and make them aware that they are at risk for ischemic optic neuropathy, which can then present with sudden loss of vision and frank a decrease in blood flow to the optic nerve. And this can certainly be followed by a type of glaucoma that we may see.
Wow. I'm like speechless. I had no idea about that, like the effect of, I mean, I know we mentioned some of the medicines, but especially that one, that's very interesting. And everybody in the chat, don't forget, drop your questions. Dr. Davison, so with that being said, what symptoms should people be looking out for so that they should know when to go get checked?
That's a great question. I get that a lot from my patients, and Barber kind of touched on this earlier by saying that glaucoma is the silent thief of sight, kind of like hypertension is the silent killer. So silent means there's not a lot of symptoms early on. And so it's not a lot for patients to look out for. We'll talk about a lot as we go through, but that's why it's important for you to get regular eye exams, because Dr. Barber and I, optometrists and ophthalmologists, we're screening for these things. We kind of know what to look for. That's why we ask these detailed histories when you come in. We don't want to get all in your business, but we really need to know what things are being managed, what you're taking for as medications, other health issues that it can influence your risk for having glaucoma. But one, in the beginning, early, not a lot of symptoms. But there are some symptoms that may present some of the more moderate advanced phase, because unfortunately I have patients come in who are not in the early phases. And so you can have trouble seeing in your blind spot. So I call that your functional vision. So over here, you get over to, you don't see a car that's in your blind spot, or if someone leaves the cabinet door open, you don't notice that and you walk into it, or someone walks up to say something to you and you don't know until they're like on you. So your functional vision, so trouble in your blind spot. Also, you can get some halos and some glare at night, or some overall blurry vision. But typically, if you notice those things, you're more in the moderate to advanced. And so hopefully, I'm sure Dr. Barber's goal as well is to not you experience those, right? So we want to get out of this, get a regular eye exam so that we can screen and catch things early. One part about it being where it's not a lot of symptoms, sometimes it makes it harder for patients to be compliant, right? I had some patients today who were having glaucoma checks, we're checking their eye pressure, and they're like, I see fine, doc. You do. I don't feel anything. You won't. And so I know it's hard for you to listen, for me to tell you to take this regularly. I'm not sure. I'm seeing myself in purple. I don't know if you guys are seeing this on my camera.
Yes.
Sure, we are. I was like, okay, purple rain.
I'll be feeling purple today. And so it's hard for patients to kind of be compliant if they don't feel any different or see any different. And so the takeaway in the beginning, you may not have vast changes in your vision, and that's good, because our goal is to maintain your overall sight throughout this diagnosis to help you manage it where you don't lose vision. And so I don't know if I need to go out and come back in, but look for a camera.
You could try. It's fine, but I want everybody to know, like, we all see it. It's not there's nothing wrong with your vision. We all see it, but I can still see you. We can hear you. So it's
okay.
If you want to, you can.
I'll try to go out and come back in and see. Okay.
Okay.
And we can keep our discussion lively and add to the fact that that was a pretty good review of looking at patients, and they don't typically have symptoms, but there is a kind of glaucoma called angle closure glaucoma, which is acute, and it is very painful. And this is a condition where the patient may have developed a mature cataract that is pushing forward, closing the drainage canal off in the eye, and the pressure suddenly can shoot up to double or triple times normal. That patient will typically present with pain, blurry vision. The eye becomes red and tender to touch, and the patient may even have nausea and vomiting from this. And this kind of glaucoma is alleviated with a laser procedure called an iridotomy. So that's the one kind of glaucoma that may present with symptoms. There is another type of glaucoma, and it is a source of closure of the angle again, and it can occur in diabetics, where by the diabetic retinopathy takes over the eye and kind of grows into the drainage canal small vessels. The eye pressure can then shoot up and cause severe pain and bleeding inside of the eye. So this is another type of painful glaucoma that we may see.
Mm-hmm. Wow. Well, I was curious about one of the, and I don't know if it is a symptom, but when Dr. Davison was mentioning the halo and those types of things. But what about
Right.
when people are seeing floaters? Is that an indication, or is that just so I
Not
know?
necessarily glaucoma.
Okay. Okay.
As you said, the eyeball is small, but there's a lot of structures back there. And so
Yeah.
that could be associated sometimes with retina changes, where it may
Okay.
indicate a hole or tear in the retina, um, or retinal detachment. Not necessarily glaucoma. I'll defer to Dr. Barber if she has anything to add on that.
Well, I would say floaters are typically uh, seen in the normal population as incidental finding
Mhm.
to aging, to the aging eye. However, it can indicate pathology such as a vitreous hemorrhage and some of the other things that Dr. Davison led us to listen about.
Okay. One thing I wanted to address, because I'm not sure if anybody else in the comments is wondering this as well, but can you explain about eye pressure? Because I know we've mentioned it a couple of times. Can you just, because I know when we do blood pressure, but what is eye pressure and how is that measured? And what are you looking for when you're checking the eye pressure? And either one of you can answer that, or both of you.
I'll let Dr. Davison lead
Okay.
off that.
And so the way I kind of explain to my patients, I tell them you have three pressures in your body. You have your blood pressure, your eye pressure, and your intracranial pressure. And they don't necessarily all influence each other. But
Mhm.
the eye pressure, there is a fluid that's called the aqueous humor. And it flows through a structure in the eye that's an angle. We call it an angle, it has a nice little structure, and that fluid is supposed to flow. That fluid is responsible for bringing nutrients and oxygen to the optic nerve, and it also helps keep the eye in shape. And so you always kind of want to think about something impeding that flow or slowing that flow down or reducing the how the flow gets out of that angle, and
Mhm.
that impediment can increase the pressure. And so when you come in for a regular eye exam, we have different ways to measure the pressure in the eye. One common way that is what we call the gold standard, the traditional way. There's usually a yellow dye that's put in, your eyes numbed up a little bit, and there's this blue light with a little tip that comes really close and it measures the pressure off the front surface of the eye. There's the puff of air test that everybody hates, but it also
Yes.
measures the pressure in the eye. And then there's something that's called eye care, where it's kind of in between the little tip that gets closed and the blow of air, but it measures the pressure. So we use the front surface of the eye to measure the pressure, and there's a number that we're looking for. I would like to note that your pressure can be within a good range, and you still have a type of glaucoma. As
Mhm.
Dr. Barber talked about, there's numerous types of glaucoma. There's some that are more common than others, but really the number that we look for is 21 and under is considered normal. Sometimes patients of color, some of the borderline numbers are like 19, mid to early 20s. Anything that's well over 21, I've had patients come in and we measure their pressure, it's 40. We're assuming that's glaucoma until proven otherwise. And so it's basically the pressure, the fluid in the eye that's responsible for keeping the shape and nourishing the eye. And if that pressure goes up, then it impedes how that fluid gets to the back of the eye, and that can lead to potential glaucoma, which is the damage to the optic nerve. So I try to make it as simplistic as possible, but
Mhm.
it's a fluid and pressure in the eye that's different than the blood pressure and it's different than your intracranial pressure. So you have a couple different pressures that have to be regulated in the body.
Okay.
Exactly.
Thank you.
And of note, we can also check the pressure for someone who is not ambulatory or who cannot make it to the office using home tonometers, for example. Or
Mhm.
there's another device called a tono pen, which is very nifty, and I use that on patients who are not able to reach the tonometer that we have in the office, the applanation tonometer. And of note, and this is very, very important, in the African American community or patients of African descent, we tend to have one part of our eye is anatomically thinner, the cornea. It can be thinner, and that can affect the accuracy of checking the eye pressure. So at times our corneas are thinner, and this can lead to a false low pressure. So if you are having your ocular pressure checked, it's a good idea to also have another test called pachymetry to see whether or not we should factor in a lower or higher number to offset the inaccuracy of the particular tonometry that you are having performed.
Okay. So is that pretty much how you diagnose whether someone has glaucoma, just by looking at the eye pressure, um, Dr. Barber? Or is it like, how would, so, well, I guess if there's not really that many symptoms, how would they know that they have glaucoma?
So the diagnosis of glaucoma, I think is usually very complex because it's not always what I'm seeing clinically. First and foremost is the patient history. So we have to have an accurate history, find out if there's any genetic predisposition. Let's find out about your medical conditions. Is there any hypertension or diabetes that's impacting your ocular health? Are you on any medications by mouth, such as steroids or any other uh, drugs that you're taking systemically that can affect your ocular health? The eye pressure measurement we talked extensively about. Again, we always include that as part of our workup. Also, we want to check the visual acuity and we want to check the pupillary exam to see if there's any impact of the movement of the pupil when it comes to damage to the optic nerve. The pupillary response can be abnormal. There are several tests that we use to diagnose glaucoma. In particular, the visual field, I think, is the gold standard. This test is kind of like a video game, and I try to ease my patients' stress about taking this test because it's painless and they always
Mhm.
want to know, well, is it going to be painful? No, it's not going to be painful. It's like a video game and whereby the patient will sit in front of a bowl and that is active with lights blinking inside of it, and they are instructed to press the button to indicate that they've seen the light inside of this bowl. The lights are coming at various directions and at various illumination thresholds. And so in the end, we have a nice pattern that can show us whether or not there's damage to the optic nerve. So that's the visual field test. The other thing that we do is we look at something called the OCT, and that's a very, very detailed ultrasound and examination of the thickness of the optic nerve, and it compares your optic nerve to that of others. And we are getting closer and closer to using artificial intelligence models to assist with earlier and earlier detection of optic nerve abnormalities and glaucoma through the OCT. I often take a photograph of my patient's optic nerve on first, suspicion of glaucoma, and I'll use that photograph throughout my reevaluation during the year to see whether or not they have more changes to their optic nerve. So that is something that we always document. Another test called gonioscopy is done as well, and that allows me to look directly at the drainage canal. As Dr. Davison mentioned, there's a fluid that's produced inside of the eye, and that fluid sometimes cannot escape the way that it is supposed to, and it is because the drainage canal, is at times clogged. So I can look directly at the drainage canal to find out what's going on there. So there you have it, a multitude of tests. And sometimes we can't do all these tests on the same day. And it
Right.
gives me the opportunity in this field to get to know my patient and bring them back and recheck the pressure also. It gives me a variety of
Hmm.
pressures. It can give me a range of what the pressure was in the morning versus it is in the afternoon when you're coming back for testing. And at the end, we put it all together, family history, medical history, all the testing, what I clinically suspect, and we make the diagnosis or we rule it out and move forward.
Okay. Well, Dr. Davison, is there a cure for glaucoma and can optic nerve damage be restored? I know we talked about vision loss can't be restored, but can the damage to the optic nerve be restored?
So the short answer is no and no. Um, that's why we're out here to promote awareness. Right now, we're making advances and we've advanced a lot of our therapies, and we'll get into some of the therapies that we advanced as far as managing it. Right now, we haven't really figured out a cure. I tell my patients there are a lot of eye diseases that we don't necessarily have cures for, but we
Mhm.
can manage the condition very well if it's caught early. to minimize as much as we can as long-term sight loss. And long-term sight loss means right now, once those nerves are lost or damaged, and that damage is glaucoma, we haven't figured out how to regenerate those nerves to the function that they were previously. And so early detection, management is the key. I don't like to say the word treatment because people think they treat, they take this drop for this time frame and then they're done. Usually, once we have this diagnosis and you're being managed, whether we're ruling it out or we're ruling it in, and we're taking drops. So we'll talk about some of the different surgical approaches. This is something that's just ongoing. And so this is a part of you. And so we'll talk about, how it impacts the life and things that you need to do because there is no cure. And right now we can't necessarily bring those nerves, those ganglion cells back.
Okay. So now I'm like, I don't know what word to use since we said treatment.
Treatment management, treatment.
Okay.
I hope people know that this is something that, like she said, she gets to know her patients
Yeah.
because you're typically going to be coming in, every quarter, every 6 months, or once a year, depending on what bucket you put into. And so treatment, sometimes these patients I know, they think they're going to do this time frame and they're done. And so it's an ongoing thing. It's an ongoing thing.
Well, what current management options, is that better? Options are available for glaucoma, and how effective are they in preventing vision loss? And we'll start with you, Dr. Davison, and then I also want to hear from you, Dr. Barbara, about this as well.
And so I'll talk about some of the more traditional approaches. What we'll get into before later on, we'll talk about collaboration. So one of the biggest things between Dr. Barbara and I is I don't do any surgery. I do a lot of co-management. I work really well with my glaucoma surgeons here in the Metro Atlanta area. And so some of the first line treatment options of late, things have changed in the last few years, but our topical therapy. So some of the things that we do is just manage the condition, taking a drop daily, right? And so there are drops that are very effective at managing the pressure, helping to reduce the chances of progression, where you can simply take the drop, a lot of cases once, maybe twice a day, with very minimal side effects overall, other than just maybe some redness when you instill the drop. One particular drop that is very common that we use that is called a prostaglandin analog. Overall, very safe, but it does cause some redness to the eyes. One thing it can cause is lengthening of the lashes, some irritation, sometimes may leading to some ocular surface or dry eye disease. But typically, a lot of the traditional approaches in the beginning in the primary care, as far as an optometrist, is topical, right? We start with the drop. And if we can't get things managed or we think the case is more advanced, then that's when we usually refer to one of our or collaborate with our glaucoma surgeons in the area. And that's when they usually take it to that higher tertiary care, where it's either she'll get into a lot of laser surgical procedures, and then there's some new procedures that are more minimally invasive. And so she'll talk a lot more about those. And so my first line is changing, especially because our detection of the cases are so much earlier. As I mentioned earlier, that this is a chronic condition. I'm diagnosed a lot of patients in their 30s and 40s. And so having to commit to a drop that long where you still have so much active life ahead of you, a lot of those different ways that we're managing are changing. But a lot of my cases, a lot of topical therapy. And then if you need something that is more tertiary, that's when I usually send you on to one of my colleagues here in the Metro Atlanta area. And so Dr. Barr will get into some of those more current therapies and as far as treatments that are available and management options.
Okay.
So I'm glad you mentioned the prostaglandin analog because one of my colleagues recently posted on LinkedIn. He brought to light the fact that a lot of these glaucoma medications with the preservatives that are in there can cause these untoward side effects, such as, especially in our patients of African descent, hyperpigmentation of the eyelids and the periocular skin, and is maybe difficult to see in our patients of color. So I just want to make people aware that the eye drops, although they are available, and we have about 4 or 5 classes of eye drops. There are beta blockers, there are alpha agonists, there are carbonic anhydrase inhibitors. I know those are big words, but there are about 4 or 5 classes of topical drops. And if once you start on the drops, it seems to be no end in sight, and you can be coming back quite a few times to see if the pressure's coming down and reaching your target. And so if you get to the point where the drops are not working anymore or you're having too many side effects, there's an option where you can be treated with a laser. Now, in the past, there was argon laser, which simply worked by coagulating the tissue in the drainage canal, improving the drainage outflow process of the aqueous fluid. But now we have moved on to something called SLT, which is selective laser trabeculoplasty, which uses a different modality. Again, the same concept. Let's open up the drainage canal and improve the outflow of the aqueous. The laser treatment is something that I consider first line at this point because it is so effective and it gives the patient the option to forego the use of drops. It is so effective it can lower the pressure by 50% or more. There are many clinical trials, which we'll talk about in a few minutes, that include the use of laser and have uh, been putting forth the laser first concept for some of our patients who don't want to be on eye drops. If you fail the laser and you fail drops, then the next step would be to consider a surgical option. And there are many, many surgical procedures for glaucoma, and these will include, at most times, making incisions on the eye. And when I have that conversation, let me tell you, in my experience, patients really, really become stressed and
Mhm.
they just simply don't want to be faced with that kind of decision where we have to go inside the eye and perform procedures to lower the pressure. So some of these procedures include um, a procedure called a trabeculectomy, whereby we would open up the top part of the eye to create the filtration. And some of the other options are to place a small kind of tube or drainage device on the exterior part of the eye. Now, some of these procedures have evolved into intraocular or minimally invasive, as Dr. Davison mentioned. And those are some things like a goniotomy, where we just strip open the drainage canal, or canaloplasty, where we canalize the drainage canal, and just to improve the efficiency of it. Um, and if you have something like a glaucoma where the pressure is 50 or higher, we can put a drainage tube that goes to a plate. So
Mhm.
there is definitely many, many options in the surgical arena. There are some emerging therapies. If I might, I can go into that, and those are very, very innovative after many, many years of research and development. Some of these therapies include implanting a device inside the eye that's just the size of a grain of rice, that has enough medication to treat your glaucoma for 6 months, and that's called the Durista implant. There's another implant that has just gained market approval that includes the implantation of a drug eluting device which stays inside of the drainage canal for 3 years, and that medication is called Travoprost. There's another one that's on the horizon that can be implanted into the lid. I think that one will also have travoprost in it as well. We don't have to go inside of the eye to implant that one. And there are many, many others on the horizon. So we're going to continue our research and development in this arena to cause minimal amount of surgical dissection of the eye, if you will. And this can improve the quality of life for our patients and possibly save the glaucoma from progression.
Well, you mentioned the clinical trials, so I thought we'd hop to that question, because why are those so important, and what what do those clinical trials look like, and how do people get signed up for those?
Well, there are many, many clinical trials in glaucoma, and there have been over 20 different NIH sponsored trials in glaucoma over the many, many years that I've been in practice. And at this moment, I just happen to be a principal investigator for one of the trials that is funded by the National institutes of health. I hope we don't get any disruption from our studies here. This trial is called the COAST study, and we're looking at the optimization of the treatment with the laser, the SLT laser. What is the optimal power? These patients are treatment naive, meaning that they're newly diagnosed with glaucoma and they have never been on eye drops and they've never had a surgical procedure for glaucoma. And they are randomized to receive a standard laser therapy treatment with the SLT laser. We would then follow them every 3 to 4 months and monitor the intraocular pressure. And at the end of 1 year, they would be randomized again to receive either an annual standard laser or annual low energy laser as a touch up treatment. So that's one trial that's ongoing. There was earlier a glaucoma laser trial to just compare patients who are receiving laser versus those who are receiving topical medication and to look at the outcomes of that. In the past, there have been clinical trials to look at laser versus surgery, uh, putting in a drainage canal type of device versus a laser that can treat the eye externally. So many, many trials over the years. To find out more about some of the clinical trials, you can visit the COAST website as well. It's spelled just like that, Coast. There are several universities that are hosting clinical trials right now. I would say the Glaucoma Research Foundation is a very, very good website to start at to find out more about clinical trials. The Mayo Clinic has a plethora of information that's available on their website. The University of California Health System, as well as UCLA, are both very, very heavily involved in clinical research and trials for glaucoma.
Okay, thank you. I wanted
Mhm.
to grab a couple of the questions from the audience. Um, let's see. Tamika Smith says she was diagnosed with glaucoma by two ophthalmologists 5 years ago, and then when she started seeing a doctor in 2023, they said she doesn't have it.
Hmm.
So is that possible that it could just go away like that?
I mean, sometimes you can be misdiagnosed, but if you were diagnosed twice by two different doctors, I would just get maybe a fourth opinion. And if that doctor says that you don't have it, I'm assuming they're running the necessary tests that Dr. Barber talked about earlier, running a visual field, the OCT, looking at your angle structure to see if it's in fact glaucoma. And if not, then what's causing some of the changes, right? And
Mhm.
so, like
Mhm.
Dr. Barber said, you need to rule it out versus rule it in. And so, if that doctor is saying it's not glaucoma, then what is potentially causing some of the changes as far as vision, pressure? But I would maybe get a fourth opinion and just make sure they're running all those necessary tests. But patients can get misdiagnosed. Typically, doesn't happen twice. I haven't seen that. Dr. Barber, have you have any feedback on that?
I would just add that if this patient has had all of the tests and if the doctors are saying that she does have glaucoma and if she's of African descent and if there's a genetic predisposition or any
Mhm.
other medical and health related predisposition to glaucoma, I would say it's better to be treated than not.
Mm. Let's see. We've got Linda Young. She wants to know, is glaucoma connected with the pituitary gland at all?
I would
Um,
answer that by saying if there is an issue with the pituitary gland whereby it is compressing the
Mhm.
optic nerve, and that is a type of glaucoma. So
Okay.
it's not necessarily, from high intraocular pressure, but it is from direct compression of the optic nerve. That is a type of loss of vision
Mhm.
from optic nerve damage. Yes.
Okay. Okay. Let's see. I think.
And I would add also that if the pituitary, in a case of a pituitary adenoma, for example, if that is managed properly, the vision field loss can be recovered. Sometimes a patient is had. I had a patient recently who was diagnosed with a pineal loma, which is a gland that is in the pituitary that, you know, can produce uh, untoward symptoms, and in particular can compress the optic nerve. And they presented with visual field loss. Shortly after the patient was diagnosed, emergently had removal of the pituitary adenoma, we were able to repeat the visual field test and showed significant improvement after the decompression was performed.
Okay, thank you.
Mhm.
So this is for both of you again. What resources are available for those who are diagnosed with glaucoma? Who should they turn to? Is there some, I know you mentioned some websites for clinical trials, but what are some resources that they can go find out all the information about glaucoma? Dr. Davison, we'll start with you.
So of course, prevent blindness is a good place to start. I have a list here. The glaucoma financial assistance information, which is under prevent blindness as well. Vision and eye health fact sheets, prevent blindness. So prevent blindness has a lot of resources. I think the
Mhm.
Glaucoma Foundation is one. You can also check your Medicare benefits. A lot of your Medicare plans will allow you to be able to have your annual glaucoma check. One is living well with low vision. Low vision is important because a lot of times, unlike some pituitary related issues, you don't necessarily get that the gain in the visual field, and so you have a reduction in the vision. A lot of times we call that low vision, meaning you're not completely blind, but you do have a impact in your overall daily life function. So finding a good low vision specialist is something to take away today. They help you just really learn how to live again with your reduced vision, whether it's looking at food on your plate, reading with magnifiers, even incorporating telescopic tools. So low vision resources, living well with low vision. NIH has some resources. There's
Mhm.
animated glaucoma videos on the NIH. So sorry, NEI. NEI resources. There's glaucoma videos there. Um, and I think we have Glaucoma Research Society, American Glaucoma Foundation, and then also there are two organizations. National Optometric Association is which is the association for optometrists of color, and then you have the National Medical Association, and then Black Eye Care Perspectives. And so, and then of course you have Google, right? No spells, Google.
Yeah.
Google, ChatGPT, GTP, ask your eye care providers. There are
Mhm.
resources. A lot of your churches partner with eye care providers in the community. Then they will come out and have discussions with you about maintaining your sight as you're aging. And so there are a lot of resources in the community. I think Dr. Barbara may have some that I missed, but I tried to read as much as I can off this list here.
That was pretty good. I might add the Academy, the American Academy of Ophthalmology is a fantastic resource. They have built a website and being dedicated to glaucoma for both the public and physicians alike. There's another group called Bright Focus Foundation, and the World Glaucoma Association is also another international group where you can find their website is worldglaucoma.org. And don't forget about the support groups of you out there. I know some of you are on Facebook. So even on Facebook, they have glaucoma support groups. There's Vision Aware, which is also a support group, visionaware.org. There's also, you mentioned the low vision programs that are available through the Lighthouse for the Blind. There's some of the programs that are available. There's an American Foundation for the Blind, as well as the Hadley Institute for the Blind and Visually Impaired. So look out for all of those. And of course, during the month of January, that is Glaucoma Awareness Month.
Mhm.
And I think there are a lot of programs committed to educating and sharing information about glaucoma during that month. So be on the lookout for events and things to brighten your education and your resource collection during the month of January.
Thank you, because I did see some people asking in the chat if there was an
Right.
eye doctor, and so this would in their area, so this would help them to go to those resources and check that out. And so our time is almost up, but I wanted to make sure I get this question in. Um, how do you get patients to engage in their eye care and become active participants in their own health and the outcomes of their condition? Dr. Davison, and then plus leave any final thoughts as well.
Mhm.
Yes, so Dr. Davison, we'll start with you.
Mine is pretty simple education. I believe knowledge is power. I
Mhm.
think being a product of two educators, that's part of what makes me kind of unique when I'm engaging my patients. I think having that relationship with their eye care provider to be able to explain what's happening, how we're going to manage and provide hope. And so knowledge is power. And so it's important that you come armed with questions to ask your eye care providers once you have these diagnoses. Support your family members who have been diagnosed with glaucoma. And just remember, education is the key. And so I like to empower my patients through educating them. And so if you take one thing away from me, get an annual eye exam, right? We've talked a lot about glaucoma. I mean, it was high level. We talked a lot. And so I don't want
Yeah.
anybody to panic here. Um, Go in for your annual eye exams once a year because you have those doctors that are there and that are our jobs to screen, make sure we don't see any added risks. And when we do, we have those educational talks with you so that way we can customize a plan for you. So that way you don't feel like, that your life is going to be significantly impacted. So routine eye exams, knowledge is power. The more you know, the more you
True.
grow and the better you do.
Love it. Dr. Barber.
I would add that having a band of friends and family that can support you is critical, so that you don't feel that you're alone in this. And early on, if you've been diagnosed with glaucoma, you should foster a lifestyle and try to remain as independent as you can in preparation for what could happen in the future by maybe perhaps having some orientation and mobility training, and make sure that you are staying aware of what your needs are on a daily basis and keeping up your skills of daily living. Also, you can look into any kind of assistive technology, like using captions and or using putting more AI into your life, having voice uh, mediated media, for example, using something like Alexa or something like that to help you with some of your daily tasks. In fostering emotional resilience is also important because quite often I see this a lot of patients become depressed once they get that diagnosis. So I think staying emotionally upbeat and being resilient and maintaining your lifestyle and your happiness, even going forward with your diagnosis, is critical. And at the same time, promote physical wellness. And even though you feel that the glaucoma can be a setback, it doesn't mean that you can't go walking anymore or that you can't enjoy a game of pickleball or something like that with
Mhm.
friends and family. Keep your physical fitness and your emotional well-being at the highest point that you can.
This has been such a great conversation, and thank you to everyone in the chat for joining in with us. Goodness. Yeah, so thank you both, Dr. Barber and Dr. Davison. This has been great. And everybody, you heard all the resources they listed. And if you missed it, you can go back and watch again to make sure you can write those down and so that you have those. And for any more information about glaucoma, you can also head over to blackdoctor.org. There's plenty of articles and resources over there as well. So I want to thank you both again for joining us here on blackdoctor.org. Thank you.
You're
And
welcome.
you got to come back, of course. There's so much more we could talk about. Well, I want everyone to have a great rest of their night. Thank you for joining us.
Thank you and have a great evening.
Thank you.
Thank you.